So Ban Ki-moon, the director of the United Nations, said back in 2009 on World Mental Health Day, providing effective mental health services in primary care settings would help to reduce the stigma associated with mental disorders, but prevent unnecessary hospitalization and human rights violations of people with mental health problems. Such a strategy makes good economic sense. It is also pro-poor. Let us this year resolve to reduce the public health burden and the individual suffering of people with mental health problems worldwide. So Ban Ki-moon was absolutely correct, and having this sort of high-profile statement made by somebody of his stature at that time was obviously extremely helpful to the movement for global mental health generally. But what impact has that had, and what progress has been made? I think the first signal sign of progress was the commitment of the World Health Organization to global mental health, first of all through the development of something called the Mental Health Gap Action Program. And this is designed specifically to mind the gap. It's about increasing the coverage, that is the availability, of community interventions in low and middle income countries. And the way that it seeks to do this is by developing evidence-based practice guidelines for non-specialists in low and middle-income countries. Which treatments work and which among them could be delivered using a task-shifting, task-sharing approach, not psychiatrists or specialists providing the treatment, but non-specialist primary healthcare workers, doctors and nurses. And these clinical guidelines have been developed in 7 priority areas, including depression, psychosis, epilepsy, dementia, child and adolescent disorders, alcohol use and suicide. The guidelines are all available on the WHO MHGAP website and have been disseminated very effectively to by the World Health Organization to governments worldwide, particularly in low and middle income countries, and the WHO is working with ministries of health to look at programs of implementation, scaling up and evaluation. Here's some of the examples of some of the types of interventions that form part of the evidence base for the World Health Organization's MHGAP intervention guidelines. And these are reviewed in the 2007 Lancet series, but I've also included some more recent evidence that's been developed. What was interesting in the 2007 systematic review that looked at all trials conducted in all parts of the world of interventions for depression, for alcohol use disorder and schizophrenia was that of the nearly 12,000 trials that were identified, 89% of those trials were actually conducted in high-income countries. Around 10% were conducted in middle-income countries, and only 1% of those trials were conducted in low-income countries. So the evidence base is small, but there are some real important nuggets to be found there amongst those high-quality trials that were conducted. This was a trial looking at delivering a talking therapy, a psychological therapy called interpersonal therapy for major depression in villages in rural Uganda. And what's notable about this is that the intervention worker is not a psychologist, but is actually just simply a member of the community with 12 years basic education who's been trained to deliver a very simple form of interpersonal therapy. And what was striking in this trial was that the intervention effects were enormous, larger even than some of the beneficial effects seen for interpersonal therapy when delivered by psychologists in high-income countries. So roughly 4/5 of those that were randomized to the intervention showed a clinical improvement, where only about 1/4 of those that had treatment as usual, i.e. no treatment, showed improvement over the same period. And the beneficial effects were maintained up to 1 year later. This next trial shows a similar pattern. This was a so-called step care intervention for women living with major depression in some of the poorest parts of Santiago in Chile. And the step care intervention involved a simple form of group cognitive behavioral therapy delivered by a practice nurse at primary care, a non-specialist, followed by referral to the local general practitioner for consideration of antidepressant treatment if improvement was not occurring with the cognitive behavioral therapy, followed by referral to a specialist if the treatment at primary healthcare level didn't work. Again, the treatment effects were enormous. They were maintained up to 1 year. And Ricardo Araya, who carried out this trial, also did an economic analysis where he showed that the extra cost of avoiding 1 day spent living with major depression for a woman in this trial would be about equivalent to the cost of a loaf of bread or a pint of milk. This is one of the very few examples, actually, of an intervention trial that has actually been successfully scaled up nationwide. Ricardo Araya managed to make effective arguments with policymakers in Chile, and this program has now been scaled up across all primary healthcare services in that country. So this is a trial of community mental health workers delivering community-based rehabilitation for schizophrenia in rural India. And community-based rehabilitation actually demonstrates that there's more to treating psychosis than providing an antipsychotic medication, that it's important to address problems of stigma and discrimination in the family and in the community. It's important to look at the activities and livelihoods of the person living with psychosis and the extent to which they're integrated into the normal life of the community. And what this first trial and a later trial published in the Lancet called COPSI revealed was that there is a significant and cost-effective benefit of providing community-based rehabilitation provided by simple community health workers in addition to the basic drug treatment for psychosis. The last example of, or one but last example of these trials is a remarkable trial conducted by Rahman in rural Pakistan, where cognitive behavioural therapy for postnatal depression was provided by what are quaintly called lady health visitors, but essentially health workers with just 12 years basic education and a year or two conversion course for health promotion within the community. And Atif Rahman was able to show that it's possible to train these non-specialists to deliver this psychological intervention, that again the treatment effects at 6 months and 1 year are enormous and very favourable for the cognitive behavioural therapy arm. He also showed some possible benefits for the infants of the mothers who were treated or not treated with this intervention, in that the infants of mothers who were treated showed a lower incidence of diarrheal episodes and also a higher rate of compliance or adherence to vaccination programs. So we already knew that maternal mental ill health had adverse impacts on the developing infant, but this study also suggested that the interventions could have benefits for the infants as well as the mothers. Finally, there's an extended program now of intervention studies conducted by Vikram Patel through Sangath in Goa in India, and the Manas trial was just one example of this, with a step care intervention using lay health counsellors to provide psychological interventions together with culture-specific intervention components such as Ayurvedic massage in the example included here. And this step care intervention was also highly effective for those conditions. So given the evidence base that exists at the moment, the exercise that was conducted in 2011, looking at what are the grand challenges for global mental health at the moment, made the clear statement through the top 5 challenges that we don't actually need therapeutic interventions. We don't need new drugs. We don't need new psychological therapies. What we actually need is ways to be able to implement these at scale in order to make them more accessible. So, for example, it was about integrating screening and routine packages of care into primary health care. It was about reducing the cost and improving the supply of effective medicines, about strengthening the mental health component in the training of all healthcare personnel, and providing effective and affordable community-based care and rehabilitation. This is where our focus needs to be in practice and research. Unfortunately, there have been recently a lot of new resources allocated for research into global mental health. So, for example, mental and neurological disorders are now prioritised both within European Union and Wellcome Trust funding programmes, with some specific calls and allocations for research into global mental health and mental health in resource-poor settings. The United Kingdom Department for International Development has renewed its research programme consortium integrating mental health into primary care, and as we'll see in a moment, awarded £6.5 million to a consortium based in South Africa, looking at implementation issues around community mental health programmes. The National Institutes of Health in the USA has funded 5 regional hubs, each for $2.5 million over the next 5 years, to actually carry out randomized controlled trials of task-shifting and task-shared care. And last but by no means least, the Canadian government, through Grand Challenges Canada, has allocated a magnificent 20 million Canadian dollars per year to a number of innovation projects, mainly led by researchers and practitioners from low and middle income countries. So if we look for a moment at the UK Department for International Development Research Programme Consortium, this programme is called PRIME, and as you see, the purpose of PRIME is to generate high-quality information on the implementation and scaling up of treatment programmes for priority mental disorders in primary and maternal healthcare contexts in low-resource settings. PRIME, which includes the Centre for Global Mental Health as implementation and evaluation partners, is based in South Africa, Uganda, Ethiopia, India and Nepal. And essentially what we're implementing here is the WHO's MHGAP intervention guide. So we see here a full list of the partners, but the key issue here, as Vikram Patel, who works in the Centre for Global Mental Health and is the Prime Research Director, points out, is that the most exciting thing about Prime is the fact that the Ministries of Health in the 5 countries and the World Health Organization have joined mental health research leaders as equal partners. This is the case, so from the very first stage of planning for the grant application through all of the stages of implementation, senior mental health representatives from the countries have been present and have had a voice in determining the way that the programs looked and how they were to be implemented. Obviously, we wouldn't have been able to achieve the delivery of the mental health programs, the implementation, in order to have something to evaluate without the backing of the Ministries of Health within these countries. It's probably the first major program where that sort of support has been received. So what do we want to achieve through PRIME? The first thing is that we need competent non-specialist health workers who are trained and supervised to be able to detect mental health problems, diagnose mental health problems, create a care pathway, that's a management plan in the first instance, and then a plan for continuing care. We need, as I'll describe in a moment, systems that link and join with each other, in particular the community, working with a primary healthcare facility, working with the District Health Management Board and with secondary care for referral. We need the treatment to be accessible and affordable. We need it to be provided equitably, so everybody should be able to access the treatment and care based solely upon need. And we want to increase the coverage of effective treatment and care. So this is the key outcome for these evaluations. Has the treatment gap for these mental disorders been closed and narrowed? So PRIME works at 3 levels: the healthcare organisation, which is the district level, the healthcare facility and the community. And far too many implementation programs of this kind have focused only on the primary healthcare facility, with the assumption that if you train non-specialists in guidelines and how to deliver them, that people will be diagnosed, people will access treatment and care, and outcomes will be improved. It's been shown over and over again that this is not the case. And so in PRIME, our hypothesis is that the bits that are missing is attention to the healthcare organisation. So the district needs to have buy-in. They need to provide governance for the programme, they need to support it with financing, by making human resources available, by prioritising the system, and by having appropriate information systems to monitor how the service is working. And we're looking in PRIME at the resources and costs that are required for local level scale up to district level. Then in the community, how is one to expect that people that have no knowledge about mental health conditions, no knowledge about the availability of treatment and care, are suddenly to start seeking help at the facility level, unless one raises awareness, unless one tries to reduce the stigma associated with mental disorders, unless one encourages early identification and referral, in particular using health extension workers who have outreach into the community to identify people living with the serious mental health conditions like schizophrenia, dementia and epilepsy, and assist them in accessing care at the facility level. So the 3 phases of PRIME are, first of all, the inception phase, developing an integrated mental health plan at district, facility and community level within each of the countries. Then an implementation phase where what we're trying to do is to implement the plan at district or sub-district level. So this is for populations of up to about 200,000 to do everything that is required so that anyone in that community experiencing a priority, living with one of those priority mental or neurological disorders would in principle be able to access evidence-based care in the local facilities. Then at the end of the implementation phase, advocating to government for scaling up beyond the sub-districts or districts where the plan was initially implemented, either to regional or even to national level, and then studying the process and the impact of that wider scaling up, including the drivers that make it more likely to occur and the constraints, barriers or obstacles to that occurring. Then finally we have the National Institutes of Health collaborative hubs for international research on mental health, and here we can see the hub leaders gathered together for a meeting in South Africa with the funders, the National Institutes of Health, and these hubs have been running for a couple of years now, and here is a list of the hubs, Affirm in Sub-Saharan Africa and Share in South Asia. Both include a large collaborative component from the Centre for Global Mental Health in London. Then we have Ready Americas in Latin America, Latin MH in Latin America, and PAMD, another consortium hub in Sub-Saharan Africa. And the aim for these hubs is really to scale up knowledge and expertise in mental health research and build evidence for the implementation of mental health interventions. I think what's interesting when one looks at the trials that are going to be included by these various hubs is that all of these include an important component of task shifting and task sharing. That's the one thing that each of them has in common, is the identification of a simple low-level intervention that could be helpful and can be delivered by non-specialist health workers at scale. So, to conclude, what are the key challenges that still face us in the global mental health movement? And there are, to be honest, many. So the first of these is how meaningfully we integrate the delivery of mental health care within primary health care and secondary care non-specialist settings. And one of the problems that exists with the MHCAP program at the moment is that it still has a rather vertical or disorder-specific approach. So there's one guideline for depression, one guideline for psychosis, one guideline for dementia. This is cumbersome for training, probably overcomplicates things for the non-specialist health workers, and has important implications for how the training is delivered, whether or not this is successful at enabling non-specialists to detect mental health disorder in general and specific health conditions, and the delivery of management programs for those conditions. So I think PRIME, the DFID program, will probably reveal as many challenges, barriers and obstacles as it will success stories for the implementation of MHCAP, and we should learn for that for the future in the way in which we attempt to train for the integration of mental health within primary care. The next is the slightly narrow focus of the MHCAP program at the moment, which focuses on mental disorders and says much less about promoting mental well-being and the prevention of mental health conditions. And perhaps this is something that needs to be attended to in the future. The second is the genuine challenges which we need to be honest about regarding the provision of psychosocial and in particular psychological, i.e. non-pharmacological interventions in low-resource settings. So although effectiveness for many of these interventions with non-specialists has been demonstrated in many trials, training those non-specialists at scale is something which is very challenging indeed, whereas training non-specialists to, for example, prescribe an antidepressant medication may be simpler. Does that mean that in the end it will be pharmacological interventions like antidepressants that will be available and psychological interventions will not? That's actually been a big problem in high-income countries, and we need to address that challenge from the very beginning in the global mental health movement as well. The next is the system levels issues. So it isn't just delivering mental health care that is problematic in many of these settings, it's delivering chronic disease care in general. because these health systems are designed mainly for the diagnosis and treatment of acute conditions such as malaria, and for single episode assessment, treatment and care. So we need to work to strengthen primary healthcare in general, both in the level, the types and the training of personnel, and redesign it so that it's fit for purpose. This involves more governance, more supervision, more political will and more investment. And we can see some of the challenges if we look at the typical delivery system within a country. This is, for example, Ethiopia and sub-Saharan Africa, and the challenges that exist for delivering community mental health care. So in Ethiopia, there's a regional hospital covering a population of about 1 million. There'll be about 4 district hospitals under that, covering populations of about 250,000. For each district hospital, there'll be about 10 health centres, with each covering a population of about 25,000. And each health centre is supported by about 5 health posts, where health extension workers go into every home in the community to carry out health promotion activities. Now, the problem in terms of delivering community mental health care is that if you look for where might be a mental health specialist, in Ethiopia you would have to go all the way up to the regional hospital to find not a psychiatrist, but probably a single community psychiatric nurse covering a population of 1 million. That person's role will mainly be to sit in an office with a very long queue of people with severe mental illness outside their door, and they never go down to the district level or certainly to the health centre level. So if we're actually wanting to deliver mental health care from the health centre, then we need to think about ways in which specialist supervision and support could actually be provided all the way down here. And in reality, that can only be done if we have some specialist resource at the district level, not only at the regional level. And the role of that community psychiatric nurse at the district level will not be seeing patients him or herself, but will instead be training and supervision of the primary healthcare staff. So it means a reconfiguring of the specialist role away from frontline care and towards training, supervision and support as well. There needs to be a lot of strengthening at health centre level as well, establishing a revolving drug budget, so psychotropic drugs are always available, providing training for the primary healthcare staff in diagnosis, management, referral and follow-up. And the role of the health extension workers will be case identification in the community, referral and community-based rehabilitation. Critical actions to support all of this. We need to get mental health on the global public health agenda where it's not well recognised or supported at the moment. We need to build more evidence for the effectiveness of implementing community and primary care interventions, as we're doing in the DFID-funded PRIME project. We need to place global mental health firmly within a human rights-based framework so that the treatment gap is seen as what it is, which is actually a violation of the basic UN Charter of 1948 and the universal access to health care. And for that we need advocacy and networking amongst diverse stakeholders, including in particular people living with mental health conditions and their families. Nothing short, in fact, of a movement for global mental health. And here you see the website for the movement for global mental health that was founded in the wake of the 2007 Lancet series on global mental health. I think there are a lot of grounds for optimism. As we've seen, there's been a huge recent uplift in implementation research funding, and there are the conditions on the ground at the moment for a concerted push, with the first evidence-based evaluation of mental health care plans brought up to district level, a truly comprehensive approach that looks at everything from governance, human resources, drug supplies, community sensitisation and case identification, and training and implementation of practitioner guidelines. There's strong support in all of the countries in which this work is currently being carried out, and there's also additional evidence on the effectiveness of innovative approaches and interventions with task shifting and task sharing approaches. There's also a big need for collaboration and synthesizing all of this new knowledge and evidence, which is happening through the Grand Challenges platform, or MIN network, which is another service provided by the Centre for Global Mental Health in order to provide access to all of these studies, evaluations, and also the intervention programs and intervention manuals that are being generated. Finally, probably the single most hopeful thing to have come out of this whole process is that the World Health Organization was charged by its member countries in 2013 to develop a mental health action plan, which lasts for 7 years through to 2020. And this plan has indicators that most of the countries of the world have now signed up to strengthen effective leadership and governance for the implementation of policies and plans in mental health, that 80% of countries should have developed such plans in line with human rights instruments, and that 50% of countries will have developed or updated their laws. To provide comprehensive, integrated and responsive mental health care. And the indicator for this is that the service coverage, that's the treatment gap, for severe mental disorders will have increased by 20%, or that the treatment gap will have fallen by 20% by 2020. To implement strategies for promotion of positive mental health and prevention of mental illness, that 80% of countries will have promotion and prevention programs, and the suicide rate will have been reduced by 10%. And finally, to strengthen information systems to monitor the resources available in the delivery of mental health care. So for the first time, we actually have a concerted action agreed upon by nation states worldwide, and the evidence hopefully converging together and monitored over the course of these 7 years in order to provide political will and enhance investment and attention and prioritization to mental health worldwide. So thanks very much indeed. I hope that this talk has helped to introduce you to some of the basic concepts and actions in the emerging new discipline of global mental health, and has perhaps stimulated your interest in some of the topics and themes that we're going to be discussing and discoursing on in detail in the Global Mental Health Masters. So hopefully this talk will serve in stimulating your interest, but also perhaps getting you thinking about questions and thoughts and ideas that you may want to share with us, in which case we will be very glad to engage online and try and answer any questions that you may have arising from this talk or about the programme that we're going to be delivering over the coming year. Thank you very much indeed.